In this chapter, we'll be discussing about fracture shaft of the femur. So it is usually sustained by severe violence. Okay, so the force can be indirect, such as a twisting or a bending force while landing on one leg, or a direct force, such as a hit directly by an object, such as in a road traffic accident. Okay. So pathoanatomy. So the fracture may occur at any site and it is equally common in upper, middle and lower third of the shaft. It can be a transverse fracture, it can be an oblique fracture, it can be a spiral fracture, it can be a comminuted fracture depending on the nature of the force. So displacements. In children, the fracture does not displace a great deal, but in adults, there is marked displacement. So the proximal fragment, see, you have the flexor compartment of the muscles which are attached to the proximal segment. So what happens is there is flexion, there is abduction of the proximal fragment, flexion, abduction and external rotation of the upper segment, whereas the distal fragment, see, the adductors are attached to it. So there is adduction of the distal fragment. Okay. So there is proximal migration or overriding of the distal fragment because of the pull of the muscles traversing the fracture. Okay, so that is what you need to remember. Next, also the unsupported fracture end of the distal segment, it sags because of gravity. So basically the upper segment, it is externally rotated, okay, it is abducted and it is flexed. The lower segment, it is adducted, okay, and it sags because of gravity. Next, diagnosis. So clinical features. There is history of severe violence followed by classical signs of fracture in the region of thigh such as pain, swelling, deformity, abnormal mobility, crepitus, etc. So diagnosis is not difficult. So usually sometimes the violence is not very significant, but the whole body force comes on the femur and it fractures it, the body force. But a pathological fracture is suspected whenever the force causing the fracture is not much. Okay. Radiological examination, again, the x-ray must include the whole of the femur, and also you need to take an additional x-ray of the pelvis as well, because pelvic fractures are also common with femoral shaft fractures. Next, treatment. So first you start with conservative methods. So traction. A fracture of the shaft of the femur can be treated with traction with or without a splint. So skin traction is sufficient in children, but in adults you require skeletal traction. Skeletal traction is given by a Steinmann pin passed through the upper end of the tibia. So Thomas splint is used to control the fragments. So Steinmann pin, skeletal traction, Thomas splint. Next, hip spica. So this is a plaster cast incorporating part of the trunk as well as the limb. So it may be a single spica only involving the fractured limb, or a 1.5. See, 1.5 as shown in this figure. So draw this diagram. It can be safely used for immobilizing these fractures in children. Okay, it has been used for adults in the past but not anymore. Now, operative methods. So you have intramedullary nailing and plating. So plating is chosen where good hold is not possible by simply using a nail. Okay, so open fractures in general are treated with external fixators initially, because see, open fractures, there is a lot of bacterial contamination. So if you do internal fixation, you are introducing more bacteria. This might cause more chance of infection. So that is why first open fractures are treated with external fixators to avoid infections. Once the wound heals or is granulating, you can switch to internal fixation. So nailing. This is a technique in which the fracture is reduced and a nail is inserted into the medullary canal. So this can be done by open technique. So open nailing, the fracture is opened, reduced under vision, and the rod is inserted. The other method is closed nailing. So fracture is reduced without opening it under X-ray control. Okay, then the nail can be introduced into the medullary canal from the proximal end, that is through the greater trochanter, or from the distal end. So all of this is done under X-ray monitoring using an image intensifier. Close nailing is minimally invasive and it is the modern counterpart. The recent addition to the nailing technique is interlocking. So the nail is locked at two ends using bolts going from the lateral cortex of the bone into a hole in the nail into the far cortex. Okay, so if this is the bone and this is the nail, goes from the lateral cortex into the nail into the far cortex. Okay, so that is interlocking. Apart from being minimally invasive, closed nailing has advantages over open nailing, as infection is much less and the healing is quicker. So closed nailing and interlock nailing are technically demanding operations. So you need a certain amount of skill. Next, you have, after nailing, you have plating. So you fix it with a thick strip of metal, especially for fractures where good hold cannot be provided by simply using a nail. So such situations are, see, if for the nail to manage the fracture, the medullary canal, it needs to be quite snug so that the nail can fit nicely. But if the medulla is very wide, the canal is too wide, the nail, it won't be able to provide a snug fit. Okay, so especially if the medullary canal is too wide for a nail to provide adequate hold, or the fracture is too comminuted, you can't use a nail, right? You don't know where you're putting the nail, which fragment you're causing more damage to, and all that. Plating technique has undergone tremendous development over the years. So you had conventional plating initially, now compression plating, modern locking plate techniques, okay, and you have pre-contoured plates as well. Okay, so then general trend is towards nailing of the shaft, fractures of the shaft rather than plating. Okay, so deciding the treatment plan, it depends mostly on the age as well. So in children, conventionally it is by non-operative methods. Lately you are using surgical methods as well. So from birth to 2 years, you use something called gallows traction. So the legs of the child are tied to an overhead beam. Okay, the hips are kept a little raised so that the rest of the body, it provides a counter traction force, and the fracture is reduced. This is continued till a callus forms, so 3 to 6 weeks. So from 2 years to 10 years also, you do conservative treatments, so different methods of traction and splintage to keep the fracture in proper alignment, and once it becomes sticky, so further immobilization can be provided by just using a hip spica. Next, so birth to 2 years, 2 to 10 years, 10 to 16 years. So in 10 to 16 years, what you do is you use something called TENS, so titanium elastic nail system. Okay, so just draw the diagram. Okay, so basically they work on the principle of 3-point fixation. So two pre-tensioned, pre-bent titanium elastic nails work on 3-point fixation principle. So they are inserted from the metaphyseal region so that no damage is done to the growth plate. Okay, from the metaphysis you insert it. Okay, this is sometimes plating is preferred in children to avoid damaging the growth plate. In adults and the elderly, so operative treatment is what you recommend. Okay, full weight bearing is allowed as soon as sufficient healing is seen on the x-ray. So what are the complications? See, fracture shaft of the humerus, there will be lot of blood loss. So on average 1 liter to 1.5 liters of blood is lost. Okay, 1 to 1.5 liters. So that can result in hypovolemic shock. So that is why start an IV line. Next, fat embolism. Thigh has a lot of fat. You fracture the shaft of the femur, some fat can enter in and cause fat embolism. So especially the patient will show signs and symptoms after 24 to 48 hours of the fracture. So that is why with you should not frequently shift the patient without splinting it properly. Next, injury to the femoral artery. Injury to the artery, injury to the nerve. Which nerve? Sciatic nerve. Okay. So both these things can happen, and infection also can happen. Late complications, you can have all 3 types of unions. So delayed union, non-union, malunion. Okay, so delayed union, especially you take a time period of 5 months. Okay, so after that it is considered delayed. So x-ray may show evidence of union, but it is not solid enough to allow weight bearing. So okay, it is better to cut short the uncertainty by resorting to bone grafting, especially if the patient is an elderly person. Next, non-union. Okay, if it is still mobile after 3 months, then you'll say it is non-union. So again, you can identify it on x-ray. There will be a lack of callus, so that means union is not there at all. Sometimes the bone ends become rounded and sclerotic. So again, there may be frank mobility because there is no callus. Okay, and there is pain or tenderness. So treatment is by revising the internal fixation and doing bone grafting additionally. Malunion. Okay, so if it is not kept in the proper position, or if it redisplaces and unites. So the deformity is generally lateral angulation and external rotation. Okay, laterally it is going, externally it is rotating. So treatment, so shortening may be compensated by giving a shoe raise. You can also go for corrective osteotomy or redo the fracture. Again, you can go for internal fixation, bone grafting in addition. And knee stiffness can also happen. The reasons include intra-articular and peri-articular adhesions, quadriceps adhering to the fracture site, and undetected knee injuries. So again, how will you treat them? So again, intra-articular adhesions, you can release them by arthroscopic techniques like adhesiolysis or gentle manipulation under general anesthesia. So you can also go for a quadriceps plasty, lengthen the contracted quadriceps tendon.